So, okay, let's start. So today we will be discussing about the ocular manifestations of systemic diseases. So here is the outline of our lecture for today. So as we all know there are a lot of systemic diseases that usually affects the eye. So we are going to emphasize them today. No? And then some of these diseases were already discussed on your previous lecture. So we'll just try to, this is just a review actually. So let's start with the vascular diseases. So there is nowhere else in the body that you can examine the eye circulation or vessels, blood vessels, so close as what we do during our fundoscopy. So your retinal arteries is similar to the arterioles in your systemic circulation. So in acute ocular ischemia, it can result to an optic disc infarction, choroidal infarction, or retinal infarction or ischemia. So in optic disc infarction, or other termed as your anterior ischemic optic neuropathy, it is caused by an interruption of your choroidal supply to the optic nerve. So patient usually complains of sudden blurring of vision on one eye. And on fundus exam, you will see a pale or optic nerve swelling. So their margins are indistinct. And on perimetry, on your visual field, there is usually altitudinal field defect. So usually, if nerve is involved, um, the field defect usually respects the vertical or the horizontal line. Unlike in neurologic diseases that it respects it is parallel to the vertical line. So there are two types of arteritic or anterior ischemic optic neuropathy. You have your non-arteritic and arteritic. So in non-arteritic, this is most common in middle age group with hypertension and arteriosclerotic diseases. So usually yung mga with comorbidities. Classic term for the nerve would be what we call disc at risk. So meaning the vessels or the retinal vessels look crowded on the disc. So you don't usually see the cup to disc ratio. While arteritic ion or arteritic ischemic optic neuropathy, it occurs in usually elderly individuals, actually more than 70 years old, and it is associated with GCA or giant cell arteritis. So typical patients, again, would be elderly with other symptoms like, so what are the other symptoms for your GCA? So this is also discussed in your IM or internal medicine. So what other classic symptoms for GCA, giant cell arteritis? So what do you find in your laboratory in giant cell arteritis? So I'll just ask it in the exam, no? So for non-ion, the treatment usually is hypertension. No? So you have to control the hypertension. While in ion or giant cell arteritis, you give the systemic steroids. So treatment in arteritic type of ischemic optic neuropathy should not be delayed because the other eye may be affected in few weeks. So that's very important. Next would be infarction on the choroid or choroidal infarction. It is usually rare and is usually attributed to the occlusion of your ciliary vessels. No? So the following findings in the retina are seen. So you have your Elschnig spots, which are mottled pigmentary areas due to necrosis of your RPE or retinal pigment epithelium. You have Sjogrens streaks or the linear whitish infarcts, the whitish part. And a Mallory sign would be the triangularly shaped infarct. So usually mga choroidal infarction seen in APAS or yung patients with antiphospholipid syndrome. So you usually see these signs. Next would be under retinal infarction or ischemia. Again, we've discussed this also already. The crow and the brow, or CRAO and BRAO. So typical fundus picture of CRAO would be pale whole retina with cherry red spot due to a patent choriocapillary circulation. And in BRAO, usually there's half opacification of the retina. And patient usually complain of sudden painless blurring of vision. So in CRAO, BRAO, sudden loss of vision on one eye. So also a cotton wool spot, is also signifies infarction or retinal ischemia. There is superficial retinal ischemia due to occlusion of your precapillary arterioles. Amaurosis fugax or transient retinal ischemia is a transient monocular visual loss with full recovery of vision around after 5 to 10 minutes. So usually they should recover, no? So if not, maybe you would think of CRAO, BRAO, other systemic diseases. So this is due to transit of emboli through the retinal circulation, and the retinal emboli arises from your carotid artery disease, and this may signify high risk for stroke. So patient would usually complain of transient curtain passing on their vertical vision. So this table shows you the different causes of transient visual loss, and it includes the retinal emboli or cerebral emboli, arterial occlusive diseases, and hematologic diseases. So these are the types of your retinal emboli: your cholesterol emboli, or also termed as your Holland horse plaques. It arises from Atheromatous plaque in the carotid artery and lodge at the bifurcation of the vessels or arterioles, retinal arterioles. And they are usually refractile and appear larger than the vessel. While your platelet fibrin, this one, is usually rare, and it comes from the great vessels of the heart and is usually broken up as they traverse the retinal circulation. While calcific emboli usually comes from your cardiac valves. They appear solid and are permanently lodged within the retinal arteriole. So this is just a table of the different appearances, sources, and of your different retinal emboli. CRVO and BRVO is also a systemic condition with eye manifestations. So we've discussed this already. So CRVO associated with increased mortality from your ischemic heart diseases and myocardial infarction. Very important to investigate the cause if you see this kind of findings in the eye. So patient would complain of sudden blurring of vision again, and on CRVO, this is a classic finding. You would see a lot of hemorrhages on all quadrants with optic nerve swelling. Compared to BRVO, again, it only involves half of the retina. So if in elderly, if this happens, so usually investigate for hypertension, diabetes. However, in the young, you should investigate more because other hematologic disorders may be associated with it, like also your APAS or also OCP use or contraceptive use. So I've discussed already the risk factors last week. So also in patients who are hypertensive and hyperlipidemic and are obese, so atherosclerotic or arteriosclerotic vessels can also be seen in their eyes. So atherosclerosis is seen in larger arteries measuring more than 300 micrometers, like your central retinal arteries. There is patchy infiltration, fatty infiltration of the intima, tunica intima with fibrosis is seen in these larger vessels. While in arteriosclerosis, it is seen in smaller retinal vessels, less than 300 micrometers, and affected vessels are usually narrowed with AV making and irregularity in the caliber vessels of the arteries. In patients with severe hypertension, so those with advanced renal diseases, pheochromocytoma, and pregnant patients, particularly mga pre-eclampsia and eclampsia, hypertensive retinochoroidopathy may happen. So here, the vessels would appear markedly constricted with impaired vision, and very important to gradually reduce the blood pressure and to so as to prevent permanent visual loss. It should be gradual reduction. So in young hypertensives, aside from constricted vessels, you could see hemorrhages, exudates, serous detachments in the retina, optic nerve swelling, and macular star may be seen. So, however, in elderly patients, you don't see these hemorrhages, exudates, because their vessels are more protected by their arteriosclerosis. So usually, they seldom exhibit a florid hypertensive retina. In chronic ocular ischemia, so particularly it involves your carotids, it is usually due to a carotid occlusive disease. Eye findings would include anterior segment ischemia, such as your iritis, IOP changes, or glaucoma, and pupillary abnormalities. And retinal ischemia can be seen as hemorrhages and exudates in these cases. So you can check for carotid studies in these cases. So CCF, or your carotid artery cavernous fistula, so this is due to communication between your carotid artery and your cavernous sinuses. So this is a typical picture of the eye with enlarged or tortuous vessels, conjunctival vessels. So you have two types, the high flow or direct CCF and an indirect CCF. So in direct CCF, it is due to rupture of your intracavernous internal carotid artery aneurysms following usually with trauma. It is marked, you have marked orbital congestion with chemosis and proptosis. So there's chemosis, proptosis, high intraocular pressure. You have retinal hemorrhages in the retina, and limitation of eye movement can be seen. However, in low flow or indirect CCF, there is mild orbital congestion with arterial, again, vessels. Episcleral vessels are arterialized with high intraocular pressure. You have also mild proptosis. So direct is more proptose compared to indirect. So indirect fistula is usually caused or spontaneous due to diabetes and hypertension. So you can request for MRI and CT, and we will note of enlarged superior ophthalmic vein or dilated superior ophthalmic vein. Also, before there is bruit, positive bruit. So you put a stethoscope, and you would hear bruit or gushing sound. If you use a stethoscope, put it on top of the eyeball, you would hear bruit. Very particular with CCF. IIH or your pseudotumor cerebri, typical patients will be young, overweight women on steroids, tetracyclines, contraceptives with endocrine abnormalities. So they have high intracranial pressure with normal CSF fluid and normal X-ray or radio findings or CT or MRI findings. You will see enlarged blind spot on both eyes, or looks papilledema. It looks, you would suspect of papilledema. However, papilledema is associated with high ICP. Endocarditis. So, subacute infective endocarditis. So, meaning you have inflammation on the cardiac valves. Typical picture, retina picture would be having Roth spots. So, these are your Roth spots. These are white-centered retinal hemorrhages. So these hemorrhages would contain fibrin thrombus, platelets, and red blood cells. So at the site of vessel rupture. So let's go now to more of the hematologic or lymphatic disorders that usually has eye manifestations in severe cases. So particularly leukemia. So you can see very eye manifestations is more common in acute forms of leukemia. So you would see different types of hemorrhages, dot blood, intraretinal, or hyaloid hemorrhages. This is due to also cotton wool spots can be seen, which could be due to occlusion of your leukemic cells. So leukemia, again, Roth spots. So Roth spots is seen in leukemia and infective endocarditis. Hyperviscosity syndromes, you have viscous blood, no, due to the cells. So hyperviscosity syndromes would include your polycythemia, macroglobulinemia, and multiple myeloma. Because of viscosity, there is reduced blood flow and would have reduced ocular perfusion. So on the findings, the retina, you would see dilated arteries and veins with some of the hemorrhages and microaneurysms. So because of occlusion, there would be capillary dropouts or non-perfusion on the retina. So treatment, of course, you should treat the hyperviscosity syndrome itself. Sickle cell disease is a heritable abnormality in the blood. No, so you have sickle cell deformity of RBC on the there is sickle cell abnormality of your RBC. So in the retina or on the conjunctiva, you would see what we call the comma-shaped capillaries here on the conjunctiva. Or on the retina, you would typically see what we call the C-fan pattern of neovascularization. So there are areas, this is unvascularized, or there's extensive capillary dropout on the side of on this side of the retina, peripheral retina. So these are C-fan pattern of neovascularization. Treatment, we do laser here aside from addressing the sickle cell disease. Neoplasm, no, so can also be seen or in the eye, no. So usually 1/3 of cases would be due to the primary tumor has not yet diagnosed, so it may be a result of metastasis. So in women, if we see this irregularly shaped yellow lesion on the retina, if we would be suspecting for neoplasm or metastasis in women, commonly would be due to breast cancer. However, in men would be due to lung cancer. And if it's both, men and women equally affected in colon cancer. So you have to investigate. So this is usually round, irregular, subretinal. It's under the retina. So because choroid or retina is usually vascularized, no, especially the choroid. So that's why they are prone to metastatic lesions. Metabolic disorder. So what metabolic disorder do you know that affects the eye? That was discussed already before. So again, this is just reiteration of your previous lecture. So we will just be emphasizing, yes. So again, diabetes and hypertension. What else? Mga metabolic and endocrine disorders. So again, diabetes mellitus. So usually there is retinopathy, lens changes, palsies that could be associated with diabetes mellitus. So we've discussed the retinopathy already. So you would see this or abnormal vessels neovascularizations. This is a proliferative type of diabetic retinopathy. So it can be the progression of retinopathy can be prevented if you have good control of your hypertension and diabetes. Lens changes. So you, as I said, if you are diabetic, you are there is high chance of having cataract or early cataract. So also, even if you don't have cataract, fluctuations on your blood glucose would have changes in the refraction. So basically, because of the lens because of the sorbitol retention on the lens, so which is also associated with having cataract. Iris changes. So in severe diabetic retinopathy, there is ischemia at the back of the eye, the tendency of the stimulus for normal vessels in the iris can also happen. So these are your rubeosis iridis, which can block your trabecular meshwork. So they are prone to having neovascular glaucoma. Palsy, so sometimes patient would come to you with sudden diplopia or sudden double vision, and you would check for the ocular motility. There would be limitations in the eye movement. So particularly the muscle supplied by your cranial nerve 3. So usually you would investigate if patient is diabetic, hypertensive. So this is also common that we see. So it is we usually observe it, and it usually regress or usually resolve after 1 to 3 months. So, but if doesn't resolve, you should suspect of other causes like aneurysm. So you have to do imaging. So, but basically we just do observation, especially if the patient is diabetic, known diabetic, uncontrolled. To lessen the diplopia, you can advise the patient to put an eye patch on the affected eye. Optic neuropathy, so severe diabetes could have, just like what I told, we've discussed a while ago, the ischemic or non-arteritic type of anterior ischemic optic neuropathy. You have a optic nerve swelling here. We also term that as diabetic papillopathy. So next would be your endocrine disorders. So your thyroid eye disease. So what is pathognomonic signs of having thyroid eye disease? What are the pathognomonic signs of PED or Graves' disease or Graves' ophthalmopathy? What do you usually see? What's the sign? What do you call the sign that you see in the picture? So yes, exophthalmos or proptosis. It could either be unilateral or bilateral. So exophthalmos is due to deposition of your mucopolysaccharide and infiltration of your inflammatory cells on the orbital tissues. And yes, aside from exophthalmos, there would be lid retraction. So you can see the superior sclera. So normally you don't see the superior sclera. So this is a typical picture of thyroid eye disease. It could be unilateral or bilateral. So if sometimes patient would come to you with, you would note that one eye looks fructose or more emphasized. So you would try to investigate that. You can request for your thyroid function tests. So again, lid retraction happens because of hyperstimulation of your sympathetic nervous system and inflammation or infiltration of your levator muscle. However, exophthalmos, again, is due to the bulk of ocular muscles and orbital fat. So remember, the pathognomonic signs of TED would be your lid retraction and exophthalmos. Other eye manifestations would be, again, there could be diplopia or restrictive myopathy because the muscles is also involved in thyroid diseases. Retinal or optic nerve changes. If there is severe compression of the optic nerve, you can see ischemia of the optic nerve, or maybe there will be swelling or blurring of vision once the optic nerve is already compressed because of orbital contents that is inflamed. And since they can't close their eyes, no, there is lagophthalmos. There could be exposure keratopathy. So sometimes you tell the patient to, aside from telling them to maintain the euthyroidism, you can give artificial tears to lubricate the eye to prevent exposure keratopathy. You can ask them to do lid taping while sleeping at night. And in severe TED, they give high-dose oral steroids. And if it involves already the optic nerve because of, or there's optic nerve compression already, or blurring of vision, severe TED, they do orbital decompression. Next would be vitamin deficiency. So this can also result to many ophthalmic manifestations. So vitamin A deficient eyes are at risk of bilateral corneal ulcers, keratomalacia, so or having a soft necrotic cornea, vital spots, very particular with vitamin A deficiency. These are whitish, wedge-shaped keratinized area in the conjunctiva. So when you do scraping here, you would see corynebacterium cirrhosis. And xerophthalmia in dry eyes, or xerophthalmia or dry eyes is also due to keratinization of your conjunctival and corneal surfaces. So treatment, you increase nutrition, particularly for the average daily requirement for children would be 1,000 to 500,000 units, and adults would be 5,000. You should also check for any causes of possible vitamin A malabsorption from the GIT. It's not usually malnutrition. Also in vitamin B deficient individuals, no, like in acute vitamin B1 or thiamine deficiency, you can see this in wernicke's encephalopathy. So there's a combination of confusion ataxia, nystagmus, and ophthalmoplegia. In chronic thiamine deficiency, known as your beriberi, you would see would be seen in patients with dry eyes or optic atrophy. B2 deficiency, seen in those with peripheral corneal vascularization, prone to blepharitis and conjunctivitis. Niacin deficiency or pellagra, you may have optic neuritis or retinitis. So with all these manifestations, no, we can say that vitamin B is important to what structure of the eye. So vitamin B is important to what structure of the eye? Particularly what? to the retina or to the optic nerve. Yes, so scurvy or vitamin C deficiency is seen in the eye, particularly having hemorrhages. So, important in clotting factors kasi yung mga vitamin C. Next would be the undergranulomatous diseases. So, we have TB, sarcoidosis, leprosy, and syphilis and toxoplasmosis. So, as we all know, TB is a great mimicker. So, it infects different parts of the body and eyes is not spared. So ocular TB is an extrapulmonary form of TB and that may also be an endogenous spread from your systemic lesion. So ocular features would include granulomatous type of uveitis. So it may be panuveitis from the anterior to the posterior segment. It may be affected. So you can also see this tubercles, it's very typical. The small grayish white, white to yellow subretinal nodules with indistinct borders that may result from a hematogenous spread of your tubercle bacilli. Treatment, usually same with your pulmonary type of TB. You give HRZE for 9 to 12 months. And aside from that, we ophthalmologists, we give steroids starting as 2 weeks. So you don't give systemic steroids at once. So very important treatment would be still the HRZE. And also while on HRZE, very important to check what while the patient is on HRZE, what do you think would be very important to monitor in these cases? In these patients who are particularly taking anti-TB drugs, what should be monitored? Yes, so of course, liver function test, but particularly you check for your color vision. So especially because of your ethambutol or your rifampicin isoniazid, usually color vision or blurring of vision can happen in chronic cases. Chronic treatment. Sarcoidosis is common in blacks, and in 40 to 50-year-old patients. It is an idiopathic T-lymphocyte-mediated multisystem disease, a non-cacheating, non-granulomatous inflammatory disease, and it initially affects the lungs. So again, there is a granulomatous type of uveitis. Typical, the treatment again would be steroids. Eale is a occlusive vasculopathy involving the peripheral retina. Typical patients would be young men with sudden blurring of vision in both eyes, and you would see vitreous hemorrhages. So it is associated with tuberculin hypersensitivity. So you work up the patient for possible TB infection. Leprosy is caused by your Mycobacterium leprae. It has a high affinity of the skin, nerves, and also in the eye. So eye manifestations would include lack of thalamus, smadarosis, or your loss of eyebrows and lashes. Iris pearls here, it's not that clear. You would see small round elevations or like pearls in the iris. So there are 3 types of leprosy: your lepromatous, tuberculoid, and dimorphous. However, ocular involvement is more common in the lepromatous type of leprosy. Syphilis is again a sexually transmitted disease by your Treponema pallidum. So very important to note, the Hutchinson's triad is seen in congenital type of syphilis. So a triad of keratitis, deafness, and having a notch upper incisors. In acquired syphilis, Like in other type of granulomatous diseases, you have the panuveitis, anterior to posterior inflammation of the eye is noted. Toxoplasmosis is caused by your intracellular Toxoplasma gondii, a protozoan. It can be a congenital or an acquired infection, utero, or following a systemic infection through cats as your definitive host. It is seen as a large chorioretinal scars with panuveitis. Treatment, take note of this treatment, these antibiotics, very particular with toxoplasmosis treatment. Next are viral infections involving the eye. So very important to know, you would always encounter this, even if you're rotating in internal medicine, would be your varicella zoster or herpes zoster ophthalmicus if it involves the eye. So typical findings would be maculopapular rash on one side of the forehead, no? And on the periorbital region. There is pain in the distribution of the trigeminal nerve, first division of the trigeminal nerve. So it may also have conjunctivitis, keratitis, episcleritis. That's why there is eye redness in some of patients, and they usually refer them to ophthalmology. So if there is Hutchinson sign or there is involvement or the lesion is seen on the tip of the nose or in the side of the nose, it means there is nasociliary nerve involvement, which would be a strong predictor for ocular inflammation or uveitis. So if there is lesion on the tip of the nose, we would usually check more for positive or for possible uveitis or anterior segment inflammation. Treatment, again, would be, of course, you give your antiviral drugs like your Valgrice, acyclovir. CMV, retinitis or cytomegalovirus, is common in 30 to 40% of HIV positive patients. So we see a lot of referrals for screening for having CMV, usually mga HIV or immunocompromised patients. So these viral infections is manifested in the eyes, especially again in immunocompromised individuals with very low CD4 count. So you would see a florid necrotizing retinitis with arteriolar occlusion and hemorrhages and edema. So treatment would be first initiation of ganciclovir, then followed by initiation of your heart or yung para sa AIDS. AIDS, again, no, caused by your HIV, and then it does not spare the eye. No? So there are a lot of manifestations, eye manifestations of your AIDS. So there is retinal microvasculopathy with cotton spool spots and hemorrhages. So usually early stages, you would see a lot of cotton wool spots on the retina, and with a known case of HIV. So in 30% of cases, eye involvement is seen in AIDS individuals. So these are also ocular features of HIV, where particularly would be your Kaposi sarcoma, a lesion seen in the eyelid, molluscum contagiosum, so you know that in derma, orbital cellulitis from spread to infection of the sinus. So also rare infections such as your microsporidium, cryptococcus, you would and pneumocystosis, you would suspect for AIDS, patient having AIDS. So mga atypical presentations sa retina in a very immunocompromised patient, you would suspect for HIV retinopathy. So check out the asynchronous lecture of HIV that I posted in your Google Classroom, so that you would be aware that HIV can affect the eye. Autoimmune diseases, of course, does not spare the eye. So also, very important, the SLE, which is a multi-system disease with autoimmune destruction of your normal tissues. Typical patients, no, mga associated symptoms, systemically with your malar rash, photosensitivity, with arthritis. Eye manifestations would have vasculitis or occlusion on the retina. So you would see a lot of cotton wool spots. So very typical picture of SLE retinopathy, cotton wool spots with arteriolar occlusions. So that's why usually SLE patients, they come to our clinic or OPD for screening. So we would check for ocular manifestations. Usually treatment would be steroids in these cases, and giving high dose steroids or immunosuppressants if you plan to give more or longer steroids. So usually the rheumatologist would handle these patients. And of course, if the patient is on on long-term steroids, what would you expect or what would you monitor in the eye? In patients with taking steroids, what would you monitor? What would you watch out in the eye? No, as a fungal infection. No, what other eye problem that you would see for patients with long duration of steroids? Cataract. So very good. So cataract. So usually they are prone to have cataract. So usually mga I don't know, I didn't emphasize more of usually mga young, mga pediatric patients who would be on steroids because of their systemic diseases. Sometimes they refer them to us. So usually they have cataract if they have been using steroids for a long time. So also, aside from cataract, we should check for intraocular pressure. Yeah, so very good. Glaucoma. So that's basic, ha? So pag steroids, cataract, and glaucoma. Sjogrens syndrome. So it is a autoimmune disease characterized by your dry eyes and dry mouth, your keratoconjunctivitis sicca, and xerostomia. So the lacrimal gland is infiltrated with your lymphocytes and occasional plasma cells on the lacrimal gland. So this would result to atrophy and destruction of your glandular structures. GCA or giant cell arteritis. So this is what I'm talking to you a while ago. So what type of optic neuropathy, arteritic optic neuropathy in GCA, giant cell arteritis? Diba, at the beginning of this lecture, I discussed the GCA. What type of acute ocular ischemia in GCA? Arteritic ischemic optic neuropathy. So, pag non-arteritic, usually mga disc at risk or yung mga hypertensive and diabetic. So, in GCA, usually elderly patients, more than 70 years old. No, I've encountered patients with GCA already. So, very other symptoms or typical symptoms, you should remember the scalp tenderness, jaw claudication, and headache. So, just like what I said, these diseases overlaps with your systemic diseases. So you should have encountered this in your internal medicine. No? Third year na kayo. So GCA. And so these are the systemic findings. So this is a granulomatous necrotizing arteritis of your large and medium arteries. So as high as in laboratory, you would see high ESR, CRP, and platelets. And definitive diagnosis for GCA would be doing temporal artery biopsy. So, but this is in states they usually do this. So here there are few who are doing the that biopsy, temporal artery biopsy. So typical patients would be those with sudden blurring of vision on one eye due to, again, arteritic type of anterior ischemic optic neuropathy, then followed by the other eye. So very important to initiate systemic steroids, high dose systemic steroids if you suspect of GCA. So to prevent the blindness of the other eye. So that's what is important here. Reiter syndrome, also known as reactive arthritis, affects young men with triad. Remember this, no? You've encountered this in your uveitis, urethritis, conjunctivitis, and arthritis. So it is associated with your HLA-B27 antigen. So in Behcet's syndrome, it is an obstructive vasculitis affecting both your arteries and veins with triad of relapsing uveitis, aphthous ulcers, and your genital ulcers. Eye involvement in these cases would be around 75%, usually panuveitis. So actually, Behcet's disease, no? So usually mga posterior uveitis, very occlusive, and the visual prognosis is usually poor. So you should treat them or follow up them very well, or refer them to necessary appropriate rheumatologists for them to prevent prevention of eye blindness. So unlike in Reiter's, which is associated with HLA-B27, in Behcet's HLA-B51. So usually during during board exam, they usually ask this one, mga HLA mga antigen. So usually they ask that during board exam. B51, B27, DR4, mga ganon. So should remember that. Yun. For VKH would be HLA, DR1, DR4. So lastly would be VKH. It's a T-cell mediated autoimmune destruction of your melanocytes. So melanocytes is seen in different parts of the body. So we all know that eye has melanin, particularly your RPE or choroid. So there would always be eye manifestations in VKH. We see them as bilateral uveitis, posterior uveitis, with multiple serous detachments, with associated systemic signs of poliosis, alopecia, white hair, vitiligo, or deafness. So again, associated with your HLA, DR1, and DR4. Treatment would be, again, high dose of systemic steroids. So that's all. So that's end of the lecture. So take home would be, in general, in treatment of these possible eye diseases. So that is a result of a systemic disease. You should meticulous treatment of your systemic condition is a must. So it's very important. So we usually co-manage these diseases or treating these diseases with an internist, particularly cardiologist, hematologist. Commonly would be rheumatologists, especially for uveitis cases. Okay, so So next week, so we'll have your last lecture, no? So um so I posted a an attendance there, no? So you have a short quiz next week. And so no, the Google Classroom I posted here. The Google the the attendance mga 10 o'clock.
Dok, hindi pa nag-a-appear sa chat box po namin.
Hindi nyo nakita. Nandyan kanina pa mga 9:53. So, please answer it now. Pasagot na lang. Apat lang yung nag-sign. Ay, 2 lang. Sige pa, sign. And then, I'll see you again next week. Mag-short quiz. And after that,
Good morning.
So, please read your book. Please read your book. So, usually, the lecture is based on the book, on your book.
Good morning po, Doc. Doc,
Yes.
wala po sa chat box yung attendance.
Meron na ngayon. Sinend ko ulit. Nakita nyo na ba?
Hindi pa rin po, Dok.
Doc, wala po, Doc.
Ayan.
Meron na po, Doc. Thank you po.
Pag late pumasok, hindi na view or ano. Okay, sige pa sagot hanggang and just read the book, no? So usually itong lecture would be just a summary of all. So if you read them again, parang you will be tawag dito, you will be reviewed for your mga retina topics. Okay, that's all. So just message me, ano ba? Short quiz muna next week and then lecture. Short lecture. Read the book. So usually doon ko naman kinuha. So I just emphasize the things that I want you to remember. Okay, so just answer the attendance. I'll see you next week. I'm thinking if I'll still give you another case discussion, but just refer to the Google Classroom if anything. If I'll post anything. So you've done a lot of activities naman. So I will be concentrating on doing your exams pa kasi. Okay, sige, bye-bye.